We'll move on now to Hafiz Abdul Aziz, who's going to be presenting to us on antibacterial dosing in ECMO. Hafiz is an excellent research pharmacist who's just started to do a bit of clinical work here in Australia. So Hafiz is did his PhD actually on continuous infusion of beta-lactam antimicrobials and was part of the Bling research team that had those very nice papers published in JAMA in 2024. But in parallel to that, he was running a research program on antimicrobial pharmacokinetics in ECMO, and we're about to hear about that. Thank you, Hafiz.
Thanks, Jason. Thank you, fellow speakers, for that excellent presentation. So the title for my presentation today is Antimicrobial Dosing in ECMO. What is the latest data? So ECMO patients are the sickest of the sickest in the ICU. They have severe cardiorespiratory failure, high infection risk, and often with prolonged ICU stays. And many of these patients, they also require CRRT or continuous renal replacement therapy, which adds further pharmacokinetic or concentration variability. So the dosing challenge is not just ECMO itself, it is ECMO plus critical illness, infection, CRRT with limited dosing guidance. Antimicrobial dosing in ECMO is challenging because there are several factors that can alter drug exposure at the same time. First, the ECMO circuit itself may increase volume of distribution or VD and cause drug sequestration. Second, drug properties matter in this case, especially drugs that are highly lipophilic with high protein binding, which increase the risk of circuit drug loss. Third, patient factors are really important, particularly renal function and the frequent use of other extracorporeal treatments such as continuous renal replacement therapy. So the key issue here is not ECMO alone, but the combined effect of the circuit, the drug, and the patient. So should we be worried? Before we assume every drug or every antibiotics need dose adjustment in ECMO, we should ask which drugs are most likely to be affected by the circuit, by the ECMO circuit. So traditionally, we are worried that ECMO could cause major drug loss through oxygenator and the tubing. This concern is still relevant for some drugs that are, as I mentioned before, that are highly lipophilic and highly protein bound. So for drugs with log P above 2, which is highly lipophilic, or with a high protein binding of above 70%, I would be more cautious. This is where practical resources such as up-to-date, such as the Northwestern Medicine Antimicrobial ECMO dosing guidance can be useful together with therapeutic drug monitoring where feasible. But currently, current clinical PK data suggests that for many antibiotics, especially hydrophilic beta-lactam antibiotics, ECMO itself is not usually the main problem. Organ functions such as renal function, the use of other extracorporeal treatments such as CRRT, critical illness often matters more than just ECMO per se. So much of my data or my interpretation comes from the ASAP-ECMO study. ASAP-ECMO stands for Antibiotics, Sedatives, Analgesics PK study, which was a prospective multi-center PK study in adult ECMO patients. The study recruited patients from 6 ICUs across Australia, New Zealand, South Korea, and Switzerland. So intensive blood sampling was performed during ECMO with around 8 to 10 samples collected per patient. So the aim of ASAP-ECMO study was to describe the PK of commonly used antimicrobials and sedatives during ECMO and assess whether current dosing achieved therapeutic targets. And with these data, we aim to generate practical dosing recommendations for patients while receiving ECMO. So importantly, this was not a single drug study. It evaluated multiple antimicrobials, allowing us to really understand whether ECMO consistently alter drug exposure or whether the effect is more drug specific or patient specific. This study has now generated several individual drug papers, which we hope collectively can help answer the question of whether ECMO itself should drive antibiotic dose adjustment. So we currently have 9 or 10 papers generated by the ASAP ECMO study. So those are the recruitment numbers for antimicrobials and also sedatives and analgesics. So let's us discuss about the ASAP ECMO study findings. So this ASAP ECMO study recruited 85 adult ECMO patients with a median age of around 45 years old, and most were severely ill, as we would expect with high Apache 2 and SOFA scores. Most patients were receiving ECMO for severe respiratory or cardiac failure, and importantly, almost half also receive renal replacement therapy, which is highly relevant for antibiotic pharmacokinetics and concentrations. So what we found is large pharmacokinetic or concentration variability across all drugs that we studied. However, the PK parameters were generally consistent with what we see in patients not receiving ECMO, i.e., critically ill patients not receiving ECMO. One major finding was that concomitant CRRT increased PK variability or concentration variability, suggesting that renal replacement therapy may be a more important driver than ECMO itself. Clinically, this matters because, as you can see, around 2 out of 5 antimicrobial concentration profiles were subtherapeutic. This is also the same with DALI. This is also the same with the SMART study, and also the same with the study that Rekha presented. So the key message is dosing in ECMO should not be based on ECMO status per se. We need to optimize ICU dosing, and we need to consider renal function and CRRT, and perform therapeutic drug monitoring or where available. But it's not only the ASAP ECMO study. We also have other large studies that describe this phenomenon. One of it is the Farm ECMO study. First, the Farm ECMO study included 44 ECMO patients and studied 9 antimicrobials. Target attainment was, as we expect, highly variable, with the poorest results for amikacin and imipenem. And then we have a study from Germany, from Kuhn and colleagues. So Kuhn and colleagues compared ICU patients with and without ECMO. Despite receiving continuous infusions, piperacillin and meropenem concentrations were lower in the ECMO group with poor target attainment for piperacillin and linezolid. And the last study was a voriconazole study by Van Dale and colleagues. So they looked at voriconazole exposure in a large retrospective ECMO cohort across multiple centers. They found poor target attainment both during ECMO and before or after ECMO, but ECMO itself was not clearly the reason. This is important because voriconazole is lipophilic and highly protein bound, so it is exactly the type of drug that we should be worried about when a patient receives ECMO. So the broader message is suboptimal exposure is common in critically ill ECMO patients, but it is not always caused by ECMO alone. So we need to be wary of drug properties, the organ function, mainly renal function, the use of CRRT, illness severity, and therapeutic drug monitoring remains critical in for these patients. So this slide is just a summary from our recent systematic review published in Clinical Pharmacokinetics, led by Chanel Ren. So where we reviewed the available adult ECMO population PK studies focusing on antibiotics. So these studies came from multiple countries, including Australia, Belgium, Bosnia, China, Denmark, France, Germany, New Zealand, South Korea, and Switzerland. Why population PK studies are important and why we focus on population PK studies for this review is because they help identify the covariates that actually drive the exposure and dosing requirements. So as you can see on this slide, across the studies, sample sizes were relatively small, ranging around 5 to 48 patients, and included beta-lactam antibiotics, aminoglycosides, glycopeptides, ciprofloxacin, polymyxin B, and linezolid. And the key covariates that these studies assess included creatinine clearance, CRRT, body weight, albumin, ECMO mode, and sometimes they included ECMO flow rate in their model. The overall message from this review was that renal function and CRRT were the most consistent predictors of antibiotic exposure rather than ECMO variables themselves. So these studies help move us away from fixed ECMO dosing rules towards more individualized and patient-specific dosing. Now, I know these few slides will present a lot of individual drug data, but I don't want us to get lost in the details of each antibiotic. So I'm just going to give a summary based on our review. So I just want us to look for the pattern here. When ECMO was tested as a covariate, was it consistently important, or were other factors, for example, renal function, CRRT, body weight, or illness severity, were found to be more important? That is the key question as we go through the evidence. Starting with the beta-lactam antibiotics, the available population PK studies are still small, as we would expect, but the message is fairly consistent. For cefepime, the main dosing considerations were body weight and creatinine clearance, and the recommendation was generally to use standard ICU dosing, standard and optimized ICU dosing, preferably with prolonged infusion. For ceftriaxone, covariates include body weight, creatinine clearance, albumin, and CRRT. Again, the recommendation was broadly standard and optimized ICU dosing, with particular attention on renal function, albumin, and our CRRT. For cefpirone, one study identified serum creatinine and ECMO as relevant covariates, but the suggested regimens were still within the optimized ICU dosing recommendations. So moving on, for other beta-lactam antibiotics as presented on this slide, the same pattern is still seen. For cefidrochol, for example, data remain very limited, but available evidence supports standard optimized ICU dosing. For piperacillin-tazobactam, standard high-intensity ICU dosing using a prolonged infusion was the general recommendation. It's also the same for meropenem. So for beta-lactam antibiotics, overall, ECMO per se should not drive dosing decision. The more important factors are renal function, the use of CRRT, MIC, illness severity, and whether we use prolonged infusion or we have therapeutic drug monitoring. Moving on to glycopeptides. So glycopeptides, they're a bit special. The strongest message is that fixed dosing is not enough. For vancomycin, several studies have been performed in ECMO patients. The common covariates that were included were body weight, creatinine clearance, ECMO, and the use of CRRT again. So the practical approach is applying a loading dose, followed by maintenance dosing guided by TDM. For teicoplanin, the data are limited, but available studies suggest that higher loading and maintenance doses are needed, especially when the patient is on CRRT. So unlike some beta-lactam antibiotics where optimized ICU dosing may be enough, glycopeptides really require early therapeutic drug monitoring because exposure for these patients are really variable. For the remaining antibiotics, data are even more limited. For ciprofloxacin, studies identified factors such as body weight, creatinine clearance, CRRT, and bicarbonate in one study. Standard ICU dosing, such as 400 milligram every 8 hours, appears reasonable, but target attainment will still depend on other factors such as renal function and the MIC of the pathogen. For polymyxin B, the available ECMO studies are really small and covariates such as creatinine clearance. Again, the use of CRT have been explored. Current data do not support a specific ECMO-based dosing adjustment. So again, the evidence point towards individualized drug dosing rather than an automatic or blanket dosing change when patients receive ECMO. So the key summary that we can gather based on the current evidence is ECMO itself is not the main problem. When I first started on the ASAP ECMO project, I thought ECMO itself was the main problem. The concern was really logical because we have a large extracorporeal circuit, tubing, and an oxygenator. So surely this must cause major drug loss and underdosing. And similarly, when I first started working on continuous infusion, I probably thought that continuous infusion would solve every problem in the world or in the ICU. But of course, the data are more complex and probably more nuanced. For example, continuous infusion is useful, especially for beta-lactam antibiotics, and it is an important dosing strategy in the ICU, but it's not for all patients. It does not solve all variability. Likewise, ECMO does matter for some drugs, particularly those that are highly lipophilic or highly protein bound. But for many antibiotics, ECMO alone does not explain everything. So my current interpretation is we should not simply dose the ECMO circuit, and we should not assume that one dosing strategy solves everything for these patients. We should dose the critically ill patients receiving ECMO using optimized and individualized dosing. So suboptimal antimicrobial dosing is common with or without ECMO, as we can see from the DALI study, the SMART study, and also the ASAP ECMO study. So despite increasing data, several important gaps remain. I'll just discuss this briefly. So first, many studies are still small, single center, and based on sparse PK sampling. We still need appropriate non-ECMO ICU controls because without controls, it is really difficult to separate the effect of ECMO from the effect of critical illness itself. And third, we need more data for newer antibiotics and even existing antibiotics. Fourth, we need studies that link dosing strategies and target attainment to clinical outcomes or patient outcomes, not just concentrations or the PK data. And finally, we need practical dosing framework that combine all the patient factors, combine renal function, CRRT, MIC, infection site, TDM, and also model-informed precision dosing. So what can or should we do? We need to optimize and customize our therapy for our patients, but how we can perform unit level intervention, such as using prolonged infusion. We can also adjust our dosing using dosing nomograms, and we can also combine the use of dosing software with therapeutic drug monitoring. I think we've talked a lot about prolonged infusion and its benefits in the critically ill patients, and certainly we can apply prolonged infusions for patients receiving beta-lactam antibiotics. I think prolonged infusion is the new standard in the ICU for critically ill patients with sepsis or septic shock. And if I can go explain a bit about the benefits of TDM. So TDM is probably the most direct way to manage the variability problem. This is especially relevant because ECMO patients can change quickly. Renal function can improve or worsen. CRT settings may change, fluid balance changes, and the circuit may be modified. But with TDM, we can identify both underexposure and potential overexposure quickly, and we can adjust our dosing based on the results. So my practical approach is for ECMO patients, use optimized dosing upfront, but where TDM is available and feasible, we should measure early and adjust the dosing quickly. So this is a systematic review assessing whether TDM benefits patients in the ICU. So my conclusion is, again, antibiotic dosing during ECMO is really challenging. So if I can summarize based on the evidence for now, is we should define the organism, MIC, and site of infection first, assess the patient covariates, so patient factors, body weight, renal function, and CRRT status. We should know the drug, assess drug physical chemical properties using log-P and protein binding, focus on the lipophilic drug and also highly protein-bound drugs, apply ECMO-specific knowledge and data if they are available, and consider optimized dosing strategies such as using or applying prolonged beta-lactam antibiotic infusions for patients with sepsis or septic shock. And if we have TDM, if therapeutic drug monitoring is feasible, we should use it and use it as a guidance to adjust our dosing accordingly for patients receiving ECMO. With that, thank you so much, and thank you, my mentors and also collaborators.
That's tremendous. Thank you very much, Hafiz.